Okay, so
where were we?
We were talking about vasopressin.
Yeah, I know.
He can pick up mid-sentence.
Yeah, I can pick up mid-sentence.
All right, pick up mid-sentence. Yeah.
Okay. So when you add the vasopressin, you're going to get a modest bump. So if you're on 0.15 of levo and you add 0.03 of vaso, you're not going to come off of levofed. You're going to go down to about 0.8, 0.07,
Sure,
0.08.
yeah.
So you're going to get a movement to something like that, 0.06, 0.07, 0.08. And then after that, you're not titrating up on your vasopressin. All you're doing is titrating up on your levofed.
Right.
And how high do you go up on your levofed? You go up until you don't feel comfortable anymore. And so now, whatever you're up to, you're ready to start a third pressor.
Yeah.
The threshold at which you start a third pressor is what?
The point at which the patient's not responsive to the amount of pressor that I have them on that I'm comfortable with.
Exactly right. So there's no data behind this. This is a time that you say, I don't like this anymore, I'm not comfortable. So for some people that's going to be 0.3 or 0.4 levo. For some people that's going to be 1 of levo. I start thinking about adding another pressor when I'm like on 0.4, 0.5.
Okay.
But again, there's no magic number. That's just style. There's no. What are you going to add then?
For me, I would add epi.
Right, and that's exactly what you're going to add. Because again, if you think about what the pressors do, you're already on levo, you're already on vaso. You're not going to add neo. A, it's much weaker and it's not going to do anything, and B, it's going to depress your cardiac output.
Yeah.
You're not going to add dopamine because it's going to have the side effects we talked about before. So that you're not simply looking at an inotrope. If your cardiac output stinks, then you're talking about adding dobutamine, but you're not adding it as a pressor, you're adding it as an inotrope. So I'm assuming you've got a good cardiac output right now.
And we've checked that SCVO2
right.
or whatever.
And so your major problem right now is squeeze.
Okay.
And so what you're going to do then is add epi. And how high can you go on the epi? You go as high as you can go. And then one of two things happens. Your patient stabilizes out, or they don't.
Yeah.
And that's all there really is to say about pressors and septic shock.
So, levofed, good agent, hits everything you need.
Levofed, first line agent.
Mm-hmm.
Most people would add vaso.
Vaso is a non-titrated.
As a non-titrated agent. Typically start earlier rather than later.
Yeah.
And then once you hit a point of levofed that you're uncomfortable with, add epi. And
that's it.
That's from a pressure standpoint. You're obviously going to continue managing the other hemodynamics,
sure.
Making sure the volume status is okay repeatedly, making sure the heart status is okay repeatedly.
Infection control.
Right. But from a pressure standpoint, that's all you need to know.
Gotcha. Cool.
What's the downside of starting epi right away?
The downside to starting epi right away is simply same thing as dopamine. You run the risk of extra tachyarrhythmias. So they're both, it's hitting the exact same receptors as levo is. It's hitting alpha, it's hitting beta 1, but it's going to have a higher impact on your heart. And so the good thing is it will give you more stroke volume. The bad thing is it will give you more heart rate. Typically, the typical septic patient already starts with a good cardiac output because A, the heart rate's fast, and B, the stroke volume is high, not low. So they don't actually typically need much more cardiac output. And so while it gives you the same relative squeeze as levo gives you peripherally, and so it's pretty easy to get your blood pressure up, it's going to do that at the expense. Sometimes it's a benefit. In cardiac surgery, it's a benefit. You want more heart squeeze. Here, unless your heart is lousy, it's going to be probably a more detrimental thing because you run the risk of arrhythmias, and your problem isn't dominantly cardiac output. If you do start out with somebody with a low cardiac index, so let's say you have somebody in septic shock, but their cardiac index isn't 3, the cardiac index is 1.8. Mm-hmm. So they have a combination of septic shock and cardiogenic shock. That patient gets treated with levofed and dobutamine, one to squeeze peripherally, one to squeeze the heart, or stop shopping. That person gets started for epi. So that's perfectly. So if your cardiac output is retained, then levofed is the appropriate place to start because you want to minimize complications. If your cardiac output is not retained, then epi is a perfect one-stop shopping place to start.
So in the emergency department, when we have an elderly person,
Mm-hmm.
you don't really know too much history. You assume there's septic shock,
Mm-hmm.
potentially cardiogenic component. Mm-hmm. It's not completely wrong to start epi.
It's never completely wrong, but you can get a pretty good look. You clearly have lots of skills in the ED that I don't have, and you can get a pretty rapid look at their heart to see what it looks like. So again, first thing remember septic shock is a warm shock. So if you feel their feet, which is the ultimate, you don't need an ultrasound. If you feel their feet and they're warm, the chance of their cardiogenic shock is pretty low. Mm-hmm. And the chance that you're going to need to start epi is pretty low. If you come in and you feel their feet and they're cold, that doesn't tell you that they're in cardiogenic shock. It just doesn't tell you they're in warm shock. So you're going to volume resuscitate them like you're going to volume resuscitate them. And then ideally, what you do is take a quick look at their heart. If you take a quick look at their heart and it's going boom, 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 then, and it looks like it's got a good EF, again, it doesn't matter whether it's 30% or 50%, they're not going to be in cardiogenic shock. And then I would make the argument that starting epi isn't right. If they're not, if their heart is barely pumping, which is unusual in septic shock, it's going to be less than 10% of the time that your cardiac index is going to be low. But if that's the case, then starting epi is a perfectly reasonable thing. If you can't get windows for whatever reason, then generally levo would still be the first thing you would start because you generally assume that your patient does have a retained cardiac index. But if you have a medical history that says, oh no, their cardiac output stinks to begin with, then starting epi in that relatively rare circumstance before you have more information would be a reasonable thing to do.
And if they come in on epi, if they transfer on an epi drip and they're still persistently hypotensive, what would be your second pressor that you would add?
So the strategy actually doesn't change then. So if they come in epi and they're hypotensive, I go back to what we just talked about. So you can always go up in the epi. It doesn't matter what it is. You can always go higher. There is no maximum dose. But I would sort of take the step backwards and say, why are they hypotensive on epi? Are they dry? Give them volume. Are they just purely vasodilated? In which case, I would preferentially actually switch them over to Levophed unless there's a specific reason to be on epi and go through the algorithm here. Or it's the right agent, and they're just on the right agent. I would go up as high as you go up. If you want to add a little bit of vasopressin, you can. But there's really nothing more powerful than epi. Adding Levophed is not going to make it like doubly powerful. Mm-hmm. And it's not like there's a max dose of epi. If you're on 1 of epi, saying, okay, I'm going to go to 1 of Levophed is actually weaker than just doubling your epi.
Yeah. So once you're on epi and you're hypotensive, you're pretty much screwed. Unless you're not volume resuscitated.
Well, it has to do with the. So if somebody's in septic shock, your goal is to get them supported up until the time that your antibiotics work, that either your source control or your antibiotics work. And so you're going to write out the storm because they're going to have this sort of cytokine storm. I'm not going to get all science and nerdy in you, but they're going to have this cytokine storm, which is going to cause the vasodilation. And now this is a race between the cytokine storm vasodilation is going to kill you no matter what we do, or we support you even though you're hypotensive and you give the antibiotics at 24 to 48 hours a chance to work. So if you're in the ED, sometimes your patient will be with you for 6 hours, sometimes they'll be with you for 30 hours. But your goal is to keep them alive to let the antibiotics work. If the antibiotics don't work, the patient's going to die. But being on 0.8 of epi doesn't necessarily mean they're going to die. It means that if you've treated them in a rapid fashion, hopefully the antibiotics will take a hold and that big inflammatory thing which is causing the vasodilation will settle itself out and they'll survive. You won't see them survive in the ED because they're going to come up to us in the ICU and it'll be a long process to get better. But that's the goal. But yeah, if you're unable to maintain their blood pressure on epi, they're going to die. That's kind of a bummer.
And on that note.
So, but we're going to generally be able to maintain their blood pressure because it's very unlikely. It's very unusual, actually, that we can't maintain somebody's blood pressure from septic shock, especially upon their first arrival. So it would be, I would imagine, exceedingly rare that somebody just from the big inflammatory stage of sepsis is going to die because you cannot maintain your blood pressure. Almost always you're going to be able to. It doesn't necessarily mean they're going to survive a week or a month or 6 months later, but I would imagine it'll be pretty unusual. And it doesn't matter whether it's on the floor in the ICU or in the ED that we couldn't maintain somebody's blood pressure to sort of pseudo-stabilize them, not stabilize them, but to improve them, keep them alive at least.
And keep them alive basically until their organs fail and they die from that. Is that the main?
Well, the goal is to keep them alive for the antibiotics to work.
Good God, you're such a bummer today.
The goal is, again, everything we do in sepsis, I don't know if we talked about this last time, everything we do in sepsis is supportive, right?
Yeah.
So we don't give them lung get better medicine. We support their lungs until their lungs get better. We don't give them kidney get better medicine. We keep them on CRRT until their kidneys get better. So pressors aren't make the blood pressure tone better medicine. They are support the blood pressure tone until they get better. So the goal is the only thing that you're doing to treat septic shock is fluids and antibiotics.
Right.
The antibiotics are actually treating it because this is initiated by an infection. And so your whole goal is to maximally support them until hopefully the treatment that you initiated that will not likely take effect when you're in the ED. If you give the first dose of antibiotics rapidly in the ED, it's unlikely the patient who's that sick is going to improve in front of your eyes, but there's a very reasonable chance that they will improve in the next 24 to 48 hours if you come on up to the ICU to visit them.